I would like to thank the organizers to have given me this opportunity. So I will briefly talk about the advances in radiation oncology. The first three studies are mainly technical with respect to radiation oncologist perspective, and the further three studies are related to multimodality treatment. So when we talk about cervical cancer, this is an important study worldwide also, which has come from our institute. In 2021, it established IMRT as the standard of care for post-operative cervical cancer patients. So this year, this is the new update of the patterns of relapse from the same cohort of patients. In addition to which, the authors have evaluated the updated RTOG guidelines. So what was done was those patients with pelvic relapse, the prior radiation therapy structure sets, treatment plans, and diagnostic images at relapse were imported, and then they were contoured according to the new guidelines given by the RTOG. And then pelvic relapses were categorized into within field of old RTOG or the parser target delineation guidelines, or within field of new RTOG guidelines. And then the analysis comprised of comparing the compared proportions of recurrences within the two guidelines. So what was seen was, with respect to the results, the most common relapses were seen in the distant sites, followed by the pelvic relapses. And what was observed, which is important, is that within the field of old RTOG target delineation guidelines, the misses were much higher, not much as such. There were three higher misses as compared to that of the new guidelines. So if at all the new guidelines would be applied, then this would lead to a further 1% reduction in the local relapse rates, but at a cost of slightly higher doses to the rectum, which may or may not be clinically significant later on. So this study now supports the use of newly published RTOG contouring guidelines in patients with cervical cancer who are receiving adjuvant radiotherapy. So the second trial is also from our institute only. The radiation oncologists would agree that it is difficult to treat cervical cancer patients with IMRT, which is becoming commoner in the day-to-day practice. So this was a prospective observational study wherein setup margins from clinical target volumes to planning target volumes for primary as well as the nodes were checked. So it comprised of 67 patients, in which almost 1,380 CBCT scans were analyzed. That is, all the CBCTs that happened during the time of treatment were analyzed, and the results were that for the nodal CTVs as such, there was a 1 centimeter margin that was required. When you see the primary or the mid cervical region, it was observed that CTV to ITV was less than 1 centimeter. But then, like seen here, the superior margin was important for the generation of ITV for the target. So I'll not go into details because there are other specialty delegates also here. So what was concluded is that the safest way to implement IMRT in resource constrained settings is where you cannot actually take CBCTs every day. Then these kind of anisotropic margins can be generated, but still there is a scope of improving the therapeutic window, because we all know that we come across organ motion in the form of uterocervical axis, and in addition to which there is bladder as well as the rectosigmoid motions. So this is another important study for the radiation oncologists which was awaited. So this is the Intertech trial. Again, our institution was a participating center for this trial. So this was a phase 2 and a phase 3 trial which tried to evaluate the role of PET-based IMRT as compared to that of a standard IMRT, with the hypothesis being that maybe by sparing much of bone marrow, the patients would be able to take concurrent chemotherapy, the compliance and tolerance to concurrent chemotherapy be more, and by which you can improve the target coverage and also improve the progression-free survival. But again, this was a negative trial, so I will not go into the details of this. But what was observed is that definitely, for obvious reasons, there was improvement in the sparing of bone marrow, which led to a decrease in the acute grade 3 and above neutropenia in patients. But there were no differences in the number of cisplatin cycles received by both the cohorts, or there was no difference in the OS as well as that of the PFS, or no difference in patterns of failure between both the cohorts. So what were the revelations of the study is that when you actually consider extended field radiotherapy, bone marrow sparing should be considered given the fact that we are going to irradiate a lot of marrow. And then what is observed is that standard IMRT has definitely some bone marrow sparing. So it is not like, what they concluded is that they should have compared this IMRT with the 3D CRT rather than an IMRT, which was the second arm of the study. So now moving on to multidisciplinary management of improving cervical cancer outcomes. This is a trial which was published in Oncology Research this year. So this was a phase 2 randomized trial which was aimed to assess the efficacy and toxicity of Endostar, which is an anti-angiogenesis inhibitor combined with that of combined with CTRT for locally advanced cervical cancer. So premise being the use of bevacizumab in recurrent cervical cancer. So here again the primary endpoint was PFS and acute toxicities. So 116 patients were enrolled, and what was observed is that the patients with VEGF receptor positivity, the 2-year PFS was 80% as compared to that of 35% in 63% in patients with VEGF receptor negative status. So, but then it was also observed that as opposed to assumption of higher toxicities in the patients who received this drug, there was similar acute as well as that of late toxicity profile. So, like I said, patients with positive expression of this VEGFR receptors had a significantly longer PFS and OS as compared to that of negative VEGFR expression. So, according to this study, this definitely improved the distant metastasis-free survival rate, but not PFS over concurrent chemoradiation. And this addition of this Endostar could significantly improve the survival for patients with positive status. So, but again, it comes from China, so it has to be taken from a pinch of salt, I would say. So then this study was actually published recently, but the abstract was presented in the last year in review also. So this is with the increasing number of oligometastatic cervical cancer patients that we're seeing. This is an important study, but though it is a retrospective study, it is a multicentric study which evaluated the efficacy and safety of SBRT in patients with oligometastatic or persistent or recurrent cervical cancers, with the primary endpoint being the rate of complete response to SBRT and the 2-year actuarial local control rates on a per lesion basis. The secondary endpoints being PFS, OS and toxicity. So 83 patients were treated, in which 125 lesions were treated by SBRT at 15 different centers. What's important to see is that complete responses were seen in almost 58% of the patients, partial responses were seen in 23%, and 12% had stable responses. So when you compare to that, when you actually extrapolate it to the oncological outcomes, it was seen that patients who had complete responses had local control rates of 89% at 2 years as compared to patients who did not respond to SBRT. And there was a significant benefit in the progression-free survival too, wherein patients who had a complete response had a PFS rate of 42.5% as opposed to 8% in patients who do not respond to SBRT. So this was translated to overall survival benefit also. But what's important is that there is a higher rate of acute toxicities which has to be kept in mind while treating such kind of patients. So yes, SBRT is safe in oligometastatic cervical cancer patients, and it becomes more fruitful when patients have complete responses. But then the limitations of this study is because of being a retrospective study, the systemic therapy details are missing in majority, and factors that influence the complete response would help in patient selection. So now this is another study which I found interesting, is that for patients with persistent, recurrent or metastatic cervical or endometrial cancer patients, what this phase 2 trial did was they did a cocktail of immunomodulatory drugs which used low-dose cyclophosphamide, aspirin, lansoprazole, vitamin D and curcumin, which started 2 weeks before that of the radioimmunotherapy, and pembrolizumab was administered 3 weekly from 2nd week onwards, and RT was given. So the primary endpoint was this is a very preliminary study, but I think this is a thought-provoking study. So the primary endpoint being an objective response rate as per the immune-related response criteria. So what was seen is that this study did not really meet its primary objective in both the cohorts, And pembrolizumab radiotherapy and this immunomodulatory cocktail had a modest but durable anti-tumoral activity. The toxicities were acceptable but definitely not negligible. So that was with respect to cervical cancer. With respect to endometrial cancer, Dr. Rohit spoke about the TOTEM study, which is also very clinically relevant, I feel. In addition to which, what we see in our daily clinics is there is a subset of endometrial cancer patients who present with stage 4, and this SEER database very nicely has evaluated the role of adding radiation, whether if it improves the survival compared to chemotherapy only, because the PORTEC 3 as well as the GOG was limited to 4A patients only, but here in addition to 4A, there are 4B patients also. So what was seen here is that radiation therapy improved the survival in patients as compared to patients who were receiving chemotherapy alone, and this effect was pronounced in patients with 4A as similar to that of the PORTEC and GOG studies. But what was interesting in this study is that when they did a histology stratified analysis, the addition of radiation to chemo was associated with improved overall survival in all histologies except clear cell, as opposed to our thinking. So adjuvant radiotherapy is feasible, but again what's important is patient selection is important, and in this SEER analysis again there is a definite selection bias, so we cannot come to concrete conclusions. So with respect to ovarian cancer again, so we after multiple lines of chemotherapy, we also come across patients who would be referred for radiation therapy. So this is one such study which was published in IJGC, where they have evaluated the role of radiotherapy in localized ovarian cancer patients. This is again a retrospective review, but I felt this was important, and this is in patients who were heavily pre-treated and who have received prior lines of chemotherapy, which range from 1 to 8. So what was seen here is that the 2-year local failure-free survival was improved in patients who received radiotherapy after receiving chemotherapy. But what's important here is that we have to remember that patients with longer chemotherapy-free survival did better as compared to patients who did not have a longer chemotherapy-free survival rates. So the risk factors have to be kept in mind. So the patients with no risk factors did favorably well as compared to patients who had risk factors. So for risk factor, it is important to see whether the patients had platinum resistance prior to delivery of radiotherapy. And what was seen is that the radiotherapy dose and the fractionation, or whether the type of radiotherapy that was delivered, whether it was SBRT or conventional, did not really matter. So again, like I said, patient selection remains a concern, but that it is definitely a modality that has to be kept in mind after multiple lines of chemotherapy. Thank you.